The answer is very simple: chocolate.
Okay.
I,
Chocolate
I'm
fixes a lot, doesn't it?
I'm not kidding. When I meet with my coder, they have chocolate. And it makes all the difference because it takes what could be a potentially not so fun interaction much more fun.
Yeah.
And so it makes all the difference. But realistically, I think the most important thing is having a good relationship with your coder. They are there to support you and they are there to help you, not to hinder your practice and not to hinder your ability to make the money that you've already made.
Welcome to Medical Money Matters, the podcast where you can find experts, answers, and resources so that you can achieve mastery over the financial and business aspects of your practice. Hello, everyone. Welcome to Medical Money Matters. I am joined today by Dr. Anne Hirsch, who is a practicing internist and a national expert on physician coding and how physicians can get paid for the work they're doing for their patients. So, Anne, welcome.
Thank you so much for having me. I'm excited to be here.
I am excited. I'm excited for you to be here, and I'm really excited about this conversation. Anne and I have had an opportunity to work together, and we both have a great deal of passion around physicians getting credit for what they've done and getting paid for what they've done. So that's the object of our conversation this morning. And I know frequently we don't hear the words coding and excited colliding in the same sentence, but today we're gonna make that happen. So I would love to just start by asking you, Anne, why you think physicians should work to improve their coding.
That's just such an easy question to answer. I think that we are doing so much work that we are not getting paid for, and we're leaving money on the table. And I think with the current climate of physicians and burnout, I think that helping people to be able to be reimbursed for what they do, I think goes a long way in terms of preventing burnout and hopefully keeping physicians in their current jobs and positions for, the rest of their careers.
Yeah, absolutely. Well, we talk frequently about money that's left on the table, and that's a great way to think about it. I often joke, I think the insurance companies have enough money, so I don't think that we need to be, leaving it on the table for them, and especially, all of our hardworking physicians really deserve to get paid. And we do talk frequently about the money piece of it, obviously, in a podcast like this, but not that money solves all of your problems, but what we see with groups is when the money part is handled, there's a lot more space for everything else. So, fantastic. Well, before we really even jump in, I'm guessing in this podcast, we're going to use a lot of technical jargon. So I thought we'd start with a few definitions. And I wondered if you could, for our audience, if you could make the distinction between CPT and HCC coding.
So CPT coding has to do with what we do. It's the way that insurance companies qualify the things that we do both in the office in terms of visits, hospital visits, and also codes for other procedures such as CAT scans, MRIs, that type of thing. So that's all the things that we code for and bill the insurance companies for. HCC codes have to do with the hierarchical categorical conditions, and that has to do with Medicare and how they keep track of the severity of patient illness and other factors. There's demographic factors that go into that as well. But HCC coding has to do mostly with Medicare and the severity of illness. And those are important things to be aware of and hopefully using your coding to maximize your reimbursement.
Yeah. Well, let's do a little bit of a deeper dive on the HCC coding because that is a special area of expertise for you and one in which you excel. I think in looking at numbers, I've seen you in the fractions of the top 1% of coders. So I love how well you understand the whole piece of the HCC coding. And with the CPT coding impacting the value of the visit, like you said, the what you do, and we've talked a little bit about, if you could move from a 99213 to a 99214 in your CPT coding, how that's worth, an extra $50-ish. And when you multiply that out times the number of visits per day, times the number of visits per month and per year, how quickly that adds up. I would love to hear you talk a little bit about how that HCC coding impacts the physician income.
So HCC coding has to do with severity of illness, as I said, other demographic factors as well, such as institutionalized patients versus patients living independently. But an average patient with an average severity of illness is considered a 1. So any patients who are healthier than that might be a zero point 0.7 or zero point 0.8, and patients who are sicker than that might be a 1.2, 1.5, 2.5, depending on their. And what that affects is how Medicare reimburses. So they use the something called a RAF score, which has to do with illness, to determine how much money they're going to pay per member per month for Medicare beneficiaries. And that's both Medicare and Medicare Advantage. So basically, it affects the bottom line for what you get paid for a patient, regardless of whether you see them or not, and regardless of your 99213, 214, or 215 code. So it really can have a huge impact on your reimbursement. And honestly, you're doing the work anyway. So getting those codes documented and sent to CMS one time per calendar year is going to hugely affect your reimbursement.
Excellent. Thank you for that. And that's I frequently talk with groups about CPT coding, and my favorite is sort of, let's look at your distribution, of your visit codes on the E&M side of the world, or the evaluation and management. And then but I believe there probably are a lot of physicians that are just not even tuned into the fact that if they're paying attention to those HCC codes and getting them in, that really does have a positive impact on the Medicare reimbursement, which my humble opinion isn't enough anyways. So if there's ways to get more, we should be doing that. So as you're seeing patients, what are some of the common HCC codes that you would put in as an internist?
Oh, goodness, there are so many. So diabetes, I mean, seriously,
Yeah, yeah.
on the top of that list: heart failure, peripheral vascular disease, obesity, COPD, and asthma, which is now going to be a reimbursed code in 2024. There's honestly, when I go through a patient chart, sometimes I'm like, oh my goodness, there's another one. And so there's just so many little things. And I think learning those codes and knowing which ones to put in can make such a difference. And so the list goes on and on. But once you kind of get them in your head, it's easy to start kind of just popping them into your chart note and addressing them every year and getting paid for it.
Yeah, yeah. Well, that's fantastic. It sounds a little like a treasure hunt. Like, oh, wow, I have to remember to tell them this patient has this diagnosis. And yeah, yeah.
Exactly.
Well, that's fantastic. Well, as you are looking at other physicians' coding patterns, what kind of opportunities do you see?
So I have seen your graphs of this for multiple different clinics. And I think in general, and I'm an internist, so of course I'm speaking from that perspective, but I think most of us have a bar graph, a bell-shaped curve that peaks at about a 99213. And I can almost guarantee you that most internists and probably family practitioners, as well as other physicians, probably are really doing 99214 levels of service the majority of the time. And we're just not coding for it and therefore not getting paid for it. So we really want to try to skew the bell-shaped curve a little further toward the right into the 99214 range and hopefully improve reimbursement in that manner.
Yeah, yeah, absolutely. And the one of the things we like to talk about a lot is in improving coding. We see a lot of coding audits that are the focus is compliance, right? So the coding auditor perceives his or her job is to come in and tell you if your note matches the code, and if there's a mismatch there. Frequently, what we see is the coder will downcode the visit and push it out if there's a mismatch between the documentation and the code that the physician chose, which obviously, although we don't talk about this much, has a depressive effect on physician incomes. So I'm fascinated by that trend, and I know you and I have had many conversations about, it's when there's a mismatch between the code and the note. The coders will frequently say it's over coded. And you and I have said many times it's actually most likely underdocumented. Like the service was provided. And so
Correct.
that's, for me, the fun part in thinking about coding is how to give physicians credit for the work they've already done.
Agreed.
So, yeah. So if you think about, going in, and you and I are excited about, doing things with groups around coding, but going into groups, what would you say would be the typical increase that a physician could expect in his or her income if they're improving their coding, if they stop and take a little time and learn about it?
Just off the top of my head, I'm thinking that a 10% increase is absolutely completely doable for the majority of people. Having said that, I really feel like it's probably more realistically 25% or even more. As you said earlier, it's about a $50 difference ish between a 99213 and 99214. And most visits are probably 99214s that, as you said, are underdocumented. And so if you think about that $50 charge times the number of patients you see times the number of weeks and months in the year that you work, it really adds up to a huge increase in your income,
Yeah.
which really helps longevity of clinics and helps prevent burnout.
Yeah, absolutely. Well, and it's as you said, the numbers easily can get into the six figures per year, and it is just kind of money that's being left on the table now. I think for lack of training and for lack of understanding about the coding rules, and we also have this. I would call it fear mongering. I don't think that's too strong of a term out in the industry about there's all this kind of myth and legend about coding audits and my reality. I'd love to hear your experience. We've seen very few coding audits, and I think I've only been aware in a sort of a first degree sense of one clinic that actually had a Medicare audit, and yet those are the things that are spoken with such fear and trepidation, and what keeps the downward pressure on the coding. So yeah, there's an awful lot along those lines. What do you think are the main things that get missed when documenting a visit that impacts its coding level?
I think it kind of depends on where the physician is starting from, obviously, but I think a lot of times it's just the things that we observe that we don't think are significant, or things that we think about that we just kind of discount as, well, that's obvious. Because to us, it's obvious because we do it every day, 15 million times a day. But to a coder or to an auditor, it really does make a difference. So, for example, the patient with bronchitis who has an exacerbation of their asthma, but they also have diabetes, and you're thinking about maybe treating them with steroids, you have to consider that they have diabetes, and that's going to really impact their diabetes. And maybe you're going to need to adjust their medications, adjust their insulin dose, that kind of thing. So there's a higher level of medical decision making that goes into that code. And so you really want to make sure you're documenting not only the bronchitis and the exacerbation of their asthma, but also their diabetes and the medical decision making that goes into making that decision and how you kind of navigate that. Similarly, things like a Parkinson's patient, I kind of sneak and watch the Parkinson's patient as my MA is bringing them down the hall, and I watch them walk. Things that maybe you wouldn't observe in the exam room, but I watch them walk and see how they're doing with their gait. Looking at people's skin, sometimes you can see from across the room without even touching them. You can see what their skin looks like, or you can see that they don't have edema, or you can see that their hands aren't swollen and red and puffy. All of those kinds of things we observe, but we sometimes fail to document in our note. And that can sometimes be the difference between a 99213 and a 99214.
That's fantastic. And as you and I were talking before we started to record this morning, the one of the big things I believe with documentation is really supporting the physician to have the systems in place so that he or she can do that documenting as efficiently as possible. Because yeah, all of the things you just said, probably all physicians evaluate all of those things for every patient. But yeah, what percentage of the time does that actually get documented? And it may seem a bit like an exercise or a bit like a game. Like, why should I have to write all that down for the insurance companies? But as you and I are fond of saying, it is a game, and let's learn how to win it. Let's make sure we're getting everything. So, but I love the examples, and for the non-clinical folks, it still amazes me every time I hear you talk about what you observe, and how much of your diagnostic brain is always at work. Observing and factoring in multiple things that may or may not ever make it to the note, but it's going into your decision making. So that's crucial. And so, if you were sitting with a physician who was just beginning to learn about coding, what advice would you give?
The first, second, and third thing, at least, would be go attend a coding seminar. learn about coding. It is something, at least back in the day when I went to medical school, they did not teach us. And so you learn by the seat of your pants, and it's not the best way to do it, I have to say. So learning about coding and going to several different coding seminars, because everybody has a slightly different approach to it. And it's going to work better for some people with one than it might work for another. And I think learning about how to do it appropriately so that you feel comfortable. And then the other thing is to get those system things in place in your EMR that allow you to be successful. So if you spend some time up front making those phrases, making the phrases about the things that you do 15 million times a day over and over, you can just pop that phrase into your note as opposed to starting from square one every time. So we'll save a lot of time. And I think particularly with some of the HCC coding we talked about, you have to document that you're either going to monitor, evaluate, assess, or treat. And one of those four things is generally going to be the case. And so I just have phrases for all of that, and I pop in the right phrase for the right approach, and I don't have to think about it. And so those are probably the two things I would say would be the place to start. And then, of course, learning about HCC coding as well. But those are all things that you'll learn in coding seminars.
Wonderful, wonderful. I love that advice too. Is sort of go swim around in that water a little bit with and talk to people who are smart about coding. And I would add maybe the coding seminars and just like the coding audits tend to be focused on compliance, which is great. And I believe, as you and I have talked, compliance should be the foundation of what you're doing. And I think it's lovely to think about, what are the opportunities here to really get full credit for the work that's done, and to kind of flip that paradigm where we say, oh, we think that visit's overcoded, to flip it to underdocumented. And our group, when we're reviewing, I think we'll see probably 83% of the time, I think was our most recent result, visits are actually undercoded, like they're documented well, and the documentation supports a higher code than the one the physician chose. So there is a lot of opportunity, as you said earlier. 10, 15, 20, 25% is not unreasonable, to think about, how physicians could increase their revenue. So
Absolutely.
I love that thought. It's just like, let's get everybody paid. So I know that you have used a scribe in your practice, and I wanted to ask you about that, how you work with that person and how you feel that supports your ability to document and code.
She is my lifeblood. I could not survive without her.
Yeah.
Honestly, I for that frequently. She really, I think, number one, I've worked with her long enough that she kind of understands and can pop things into the note that she knows I've done, even though I may not say to her directly, hey, I did this, this, and this. But
Mm-hmm.
I also sometimes if I don't say I did this, this, and this, that she will fail to put that in the note. And so I
Mm-hmm.
have to kind of be vigilant, and it's really on me because I'm not telling her what I actually did. But definitely she is able to see the decision making that goes into the codes. She's able to see, because she's kind of standing back and looking at it from a different perspective, she's able to see what things I'm actually addressing, what things I actually tell the patient. And it's funny, sometimes I'll catch things she missed that I think are really significant, like, hey, there's a drug interaction here you need to be careful about, and she'll forget to put that in.
Mm-hmm.
But those kinds of things that we do use in our medical decision making increase the level of our potential coding. And so, sometimes I'll pop those in. But once you get your scribe trained, they are like gold.
Yeah, yeah, wonderful. And we had an earlier episode, all about scribes and all about documenting. What we have found over the years is that the break even on a scribe is about 2.5 patients a day. And I would almost want to back up on that statistic and say, if you probably write document and write code 3 visits a day, you've paid for the scribes. So, and that I had conversations with you and others who use scribes. It saves hours a day in documenting. So, I love to see groups that are, investing in scribes, and now we're seeing the rise of AI scribes, which are getting more and more accurate. And so utilizing those kinds of tools, as you said, getting your templates and your quick text or your quick phrases or whatever built for the things that you're constantly documenting over and over to save time, make that visit documentation much more effective. Always, those are good investments in time, little setup things for your system, or investing in scribes really does. I've seen that uplift the groups. One of our clients, I think, was about 35% year over year increase in revenue after they added a scribe. And some of that was volume and some of that was coding. Yeah, like they were just able to see more people because the documentation was that much quicker. So there's, I believe, a lot of gain to be had in just, yeah, really wrapping your arms around that and getting your stuff documented. So let's shift gears a little bit and think. And I made a statement that some of the coding for compliance has had a depressive effect on physician income. And I want to be clear that's not a statement about CPCs in any way, shape, or form. I know a lot of people out there doing really great work. And their training is to minimize the risk of coding audit and fraud. And so they are doing what they believe to be the right thing. And you and I have had conversations about when that feedback loop breaks down. So if there's a CPC in the office doing the coding, and or reviewing the coding for the physician, when they find a mismatch between the note and the documentation and the code, then their desire is to make those two things match. And if they've had a conversation with a physician that might have been a little scritchy, or their feedback might not have been welcomed, we see a lot of times where the CPC doesn't go back to the physician after that, like that feedback loop breaks. And so what would be your advice for groups who are using CPCs and kind of how to effectively use them?
The answer is very simple: chocolate.
Okay.
I,
Chocolate
I'm
fixes a lot, doesn't it?
I'm not kidding. When I meet with my coder, they have chocolate. And it makes all the difference because it takes what could be a potentially not so fun interaction much more fun.
Yeah.
And so it makes all the difference. But realistically, I think the most important thing is having a good relationship with your coder. They are there to support you and they are there to help you, not to hinder your practice and not to hinder your ability to make the money that you've already made and get that paid to you. And so I think the important thing is that you have a good relationship with them. And so trying to not be scritchy is really important. That's from the physician side because, it is frustrating. We are busy. We don't want to hassle with this. But if you recognize that that's $50 potentially per patient you're leaving on the table, it makes it a little bit easier to say, okay, I do really need to listen to this person. And I think the other thing is that the coders really need to feel very comfortable coming to the physician and saying, look, this note clearly indicates that you did a level 99214 service for the patient. You just didn't document X, Y, or Z. And if you add that to your note, we can get you paid. And I think once they do that a couple of times, my belief is that that's going to make a huge difference in terms of how the physician documents moving forward so they don't have to talk to their coder so often.
Mm-hmm. Mm-hmm.
That can make a huge difference. So I think it's really important that my personal belief is if a coder ever changes a code up or down, that they should come back to the physician, maybe not on a daily basis, but weekly or monthly, and meet with them and show them what differences they're seeing so that they can make adjustments in how they code moving forward because it really can impact the bottom line. So I feel like that's an important thing to help learn how did you undercode and how did you overcode and what did you do that makes those differences.
Yep. Yep. Oh, that's wonderful advice. I might go so far as to say if the coder is going to thinks that they should move a code down, that actually should go back to the physician and there should be some conversation. And the coders we've met over the years, I sort of sort them into two buckets. One are the absolute rule followers that will come in and say you can't. You can't push this out because it's overcoded, who are looking to make sure that we're following the rules. And on the one hand, I applaud that. On the other hand, what I find are the more effective coders are the ones who are looking for opportunity. So they're reading the chart note and they're looking at it and saying, right now, if this were audited, we've coded a 4 and it wouldn't stand up. But also reading between the lines in the chart note, like there was a lot going on here. And there's one or two sentences in here that indicate to me the patient had several things that were being reviewed. And like you said earlier, you're constantly observing. But the coder who can look at that and go back to the physician and say, let's get the rest of the stuff in this note because there was clearly more going on. Those are the coders who code for opportunity. Again, always sitting on that foundation of compliance, but who are really looking to say, how do I get my doctor paid for what they did. Those are the ones I really love. Those are the gold. Right? So,
Agreed.
and especially if you're feeding them chocolate, then all things are good. Yeah,
Absolutely. Can't not fix anything with chocolate.
that's right. All right. Well, bringing it home, I've loved this whole entire conversation. I would love to wrap up with from you your top 5 coding tips that all physicians should have.
If I really get into it, I probably have 50 or 100, but I'll
Okay,
try to.
good. We'll have another podcast. We'll do five through 50. Yeah.
So I would say the first thing is, physicians are lifelong learners in general. We go to CME. We always want to find out the latest information. We do that with medical knowledge. I think we need to do that with coding as well. So I think attending coding classes, not only as you are starting your career, but continuing to do that periodically, especially as things change. Things change every year. CMS is constantly making changes. Continuing to make sure that you're up to the latest information about coding is really important. The second is coding assertively and making sure that you're documenting what you did in the visit to make sure that you're coding appropriately for what actually happened in that visit, as we've talked about several times during this podcast. I think that's really important to get paid for what you've already done. I think learning about HCC codes is huge because, again, if that's affecting the bottom line in the RAF scores and how much you get paid per member per month, that's kind of money that's coming into your clinic without you even doing anything or realizing. And so it's kind of that passive income. And if you can get the passive income up, what you're doing in the office on a daily basis isn't going to be as significant. And so you've already got that baseline level of it's kind of like a morphine pump. Your
Yeah.
morphine pump constantly giving you a little bit of morphine all the time. Maybe morphine's not the best way to but you know what I mean? You're getting a
Yeah.
little bit all the time, and then your CPT codes and what you do in the office are the hit that you take when you push the button
Yeah.
to get extra money. And so it's just a nice way to get that baseline money coming into the clinic. I think being sure that that your documentation supports the code that you have picked is really important. And that's where talking to your coder is very helpful because there may be that 1 or 2 phrases that you didn't include in your note that would allow it to go from a 99213 to a 99214. And again, not leaving money on the table, I think, is huge. And again, helps the bottom line for clinics and helps prevent burnout and keeps people in their careers longer. And I think the other thing is we kind of talked about this earlier. Don't sell yourself short for the things that you do. We think, oh, it's just hypertension. That's so easy. And we don't think that that's a longitudinal problem that we are coding for.
Yeah.
And there's a new code coming out in 2024 that allows us to bill an extra $20 for Medicare beneficiaries for longitudinal management of chronic conditions.
Yeah.
And you think about all the things that we manage, and that's a lot. And if you add code G2211, you can make $20 extra per Medicare patient. So I think it's important that we don't sell ourselves short for the things that we already do and make sure that we document to get paid appropriately. And I think that can go a long way.
That is wonderful. Well, Anne, thank you so much. This has been a fascinating conversation. I know our audience is going to appreciate it, and I appreciate you taking the time today.
Thank you so much for inviting me. I feel humbled and honored to be in your presence and talking about this fun topic. Thank you.
Oh, I'm delighted. Thank you. You can find more information online at medicalmoneymatterspodcast.com, and you can subscribe to the Medical Money Matters content website for physician leaders to find budget templates and many other tools. We've included those links in the show notes. As I like to close out these podcasts, congratulations on taking the next step in your professional development and for making the commitment to learn about the financial and business aspects of your practice. I look forward to being on this journey with you and send you my heartfelt gratitude for all that you do for your patients all day, every day.